Okay, everybody, it's 2 o'clock. We know we'll have more people come in, but it's important for us to get started on time. So good afternoon, everybody. Welcome to this year's 2021 Matrix and Great Plains Track Summit featuring disruptive technologies and innovations. During this poster session, we'll have 3 posters that will give insight into innovations and present new ideas to consider. Detailed data gathering and research into each of these areas, what makes undertaking telehealth research beneficial to all of us. Each presenter is going to be given 10 minutes to introduce themselves and explain their poster, and the remaining 4 minutes will be left for questions and comments. If you prefer, you may choose to use the chat feature on your screen to ask questions. In order to make sure all our presenters are scheduled for their allotted time, we will stay firmly on the 14-minute schedule for each. I want to thank all the poster presenters and our audience for joining us today. And I encourage all of you to vote for the People's Choice poster presentation in the Summit app. If you have any further questions or would like to continue discussion with the presenters, go to the attendees section of the Event Mobi app and message them directly. You can connect at the networking tables in the exhibitor space or email them directly outside of the conference. So let's get started with Michelle Conkley's poster.
All right, thank you so much. Let me just get this shared. You guys aren't seeing my poster, right?
No.
Okay, let's try.
Now we see your passport.
Oh boy, don't steal any of that. How about now?
That's it, got it.
All right, great. So thank you so much, everyone. So my name is Michelle. I'm a 4th year medical student at Sidney Kimmel Medical College in Philadelphia, along with my co-presenter, Caitlin Weiss, who's also a 4th year med student. And our project is on the patient experience for using telehealth for primary care for people with intellectual and developmental disabilities. So our institution has a program called the Jefferson Continuing Care Program. That's a medical home for people with complex childhood onset conditions and intellectual and developmental disabilities. So if you're not familiar with these, some common intellectual and developmental disabilities include autism, cerebral palsy that can have a cognitive component, and various other disabilities. It's a very diverse field. So at the beginning of the pandemic, as with almost everything else, we quickly had to transition to using telehealth. And this medical home provided a unique opportunity to look at this patient population because in the literature, there really isn't very much on using telehealth to provide primary care for this population. Some of the other studies that have been used look at using digital implications for weight loss or behavioral interventions for this population, but none really in primary care, and none that really looked at the patient or the caregiver of the patient, whether that be a parent or another family member, and how telehealth impacted their experience. So we hypothesized that for this population, telehealth would be readily accepted, especially because a lot of people in this population have transportation difficulties or medical equipment or complex home situations. So we set out to create a patient experience survey.
Yes, and so I will talk about that briefly. So we wanted to know how patients did with telehealth. We wanted to know quickly. So we started off by using a validated survey at our institution that is sent to all patients who use telehealth, asking about their experience and if they were satisfied with that platform. And we modified it slightly to add a few additional questions to know about the patient's primary diagnosis that qualified them to receive care within our clinic. We wanted to know if they lived alone or if they lived with family members or caretakers. And we wanted to know a few other things such as, the level of daily support they needed or if they were independent and functioning, and a few questions about income and family makeup. But other than that, we started with our institution's validated survey, and we sent that out to all patients who had had a telehealth visit between March 16th, which is when the city of Philadelphia required us to move immediately to online services, through May 5th. And that gave us 38 patients. We sent it to all of their emails that were listed in their medical chart. And we gave everyone a phone call just to let them know about the survey, to answer any questions that they might have had, and to let them know that we were looking for their feedback if they wanted to offer it to us. And that survey was open for 5 weeks in October. And when it closed, we analyzed the data using SPSS to kind of get our results and our key takeaways.
So we had 14 of the 38 patients or caregivers that we set the survey to respond. So we had a 37% response rate. So while not huge, this was a pilot study. We found that patients used a variety of different devices, phones, iPads, computers. They weren't really concerned with the device itself. They had a couple minor technological issues like a dropped call, and then that visit turned into a FaceTime or a phone call. So none of the technological issues prevented the visit from being completed. So in figure 1 here, you can see our responses to kind of the patient satisfaction portion of the questionnaire. And you can see that all for except this first question, that telehealth was easy to use, patients unanimously agreed or strongly agreed with the remaining questions, including that they were satisfied with their telehealth experience, that they would use it again, and that they would recommend it to a friend, etc. The one response we had here was a person disagreeing with the statement that telehealth was easy to use. In table 1 down here, you can see our patient demographics, which shows that mostly this survey was completed by parents or caregivers, but 2 patients did complete the survey independently. We had a variety of ages, sexes, races, family incomes, and as you can see here, the 2 most common diagnoses among these patients were autism and cerebral palsy. Interestingly, in figure 2, here you can see that telehealth is often framed as a way to provide access to care for people that ordinarily would not be able to access their physician. But here, 10 of our 14 respondents said that if telehealth weren't available today, they still would have gone into the office to see their primary care provider, while 2 would have gone to an urgent care ER, and only 2 wouldn't have seen a clinician at all. We also asked for some qualitative feedback from our patients, including what would they like to see in telehealth in the future. And they said that they would like to see more telehealth for various things, including neurological and psychiatric visits, which is a previously studied and validated, telehealth is accepted in this population for psychiatric and behavioral interventions, as well as urgent care and medication refills. And some of their suggestions, including making the technology easier to use and integrating with an app like telehealth platform that our institution already uses for other things, such as seeing test results.
And so to dive into our discussion a little bit, we were relieved to know that most patients were satisfied with their experience, and would want to use telehealth again. And so we contextualized this with the chart review that we did at the same time, looking at the visit outcomes that we had done, and compared that to visits that had taken place in person, supporting that the idea that it's a feasible and acceptable way of providing primary care to the population, if necessary and if chosen by the patient and caregiver. And know that there's support from this survey for applying telehealth beyond just primary care, as Michelle just mentioned. And something we wanted to touch on within that is a lot of our patients are very unique. They have very unique services they use, and unique abilities or care needs that they have. And so individualized plans would definitely be necessary in kind of taking that step forward to find out which transition to telehealth for patients. Obviously, these takeaways are somewhat limited in that we only had 14 patients respond to our voluntary survey, but we were encouraged by the results, and we think that there are some specific barriers that are faced by this population that telehealth can make a lot easier. While we know that patients, most of them would have come into the office that day had that been an option, most of our patients replied that it did save them time and money, and that they'd recommend it to a friend or they'd be interested in using it again. So we're encouraged by this initial feedback and are thinking about other ways to increase access to high quality care while using telehealth.
So some of our future implications, including some questions for you all, we like the idea of having kind of a patient focus group and asking patients what things could we do to this telehealth app to make it easier for you or your caregivers to use. So some of the things that we came across in reviewing the literature are principles of universal design, which are things as simple as easy to read fonts, high contrast web pages, the ability to use devices other than a mouse or a keyboard to control the site. So we anticipate that these things would be widely accepted by this population, and also some differences in what barriers are encountered when the patient is using the telehealth platform versus the parent or caregiver. And also, what improvements could we make to the interface itself in terms of where the text is on the page? So as telehealth continues to expand after the pandemic, which we all know is a change that's here to stay, we do anticipate that fewer and fewer challenges will be encountered as these interfaces become more widely used and more refined. We'd love to hear from you all if you have any thoughts from the provider point of view in terms of how we can modify a telehealth interface or what we can do to the experience in order to make it more user-friendly for both the provider and the patient with IDD, or if any of you have experience using telehealth for patients with IDD. So thank you so much for your time.
Okay, guys, we can open up for questions. We'll do our best to maybe, I think you can, if you like, open up the microphone or use your chat to ask questions.
I'm curious, Michelle and Caitlin, did your caregivers have any challenges in managing both the visit and the patient? Because I'm assuming they both had to be in the same, kind of time and place, and it could be difficult for them to manage the person that's their family member as well as the telehealth. Was that a difficult process to juggle?
Neither Caitlin and I were actually present for these visits as we're medical students. Caitlin, do you have any more insight from your data collection?
And I think it actually was somewhat helpful. It was really helpful for our family physician who runs the clinic to see patients in their comfortable environment. We had patients kind of taking us on a tour of their house. I had one patient showing me his piano that he loves. So I think it kind of made the visit easier in a way and a little bit less stressful. We weren't in, a foreign environment in the office together. So I think in some ways it was helpful, but obviously, it is true we're juggling two things at once, making sure that the patient was comfortable and that we were connected and that we were talking to each other. But it was also helpful in some ways, and was also possible, that we would be able to talk to the caregiver while the patient was doing something else like coloring or doing an activity to kind of address any concerns they might have and have some of that more time to talk. So I think, kind of like you mentioned, some benefits and some challenges there.
Okay, we do not have any questions yet through chat. We still have a minute or two. Let me just ask the question. I was really kind of surprised by the primary care aspect of this, because we often think of telehealth, especially with this population with specialty care. Did anybody that was doing the visits have a thought for maybe how the responses would compare versus these patients' experience with specialty care?
That's something we've kind of thought about going forward, because our institution does have this validated survey that they distribute to everyone who uses the telehealth platform. So, we were kind of thinking of comparing our patients' experience in primary care to patients without IDD's experience in primary care, but that's a really great idea going forward. I like that. We'll definitely bring that up. Thank you.
Okay, guys, I think we probably have one more minute. Is there anybody? I see I caught Michelle as she was answering something on text while I'm asking her. So anything else? Anybody want to open your mic up, ask a question?
Hi, yeah, I was curious. It seems like you guys or the patients have fairly good access to care if they would have gone to their primary care provider had it not been available. Are you guys in a urban area? Did you look at sort of the geographic location of patients?
Yes, we did. We are in an urban area. We're in Philadelphia. And some of our patients, even ones who answered the survey, which isn't data that we shared, but travel more than an hour to come to our specialty clinic. So we are kind of looking at a patient population that does have access to kind of find us as a new resource as they're transitioning out of pediatric care, which is much better organized for folks with complex conditions, as we all know, but do have, either themselves for them to sort of locate our clinic, although we do a lot of outreach with the local pediatric programs. We know, and we're seeing on our first graph here, that they have slightly better access to certain things and are willing to come to us if necessary.
Looks like we have about a minute. Michelle, if you wouldn't mind, take down your slide. Let's bring up the next slide, but we can give ourselves a minute or so if anybody has one final question. Okay, Sarah and Vivian, if you guys would bring your slides up, please. Any more questions for the first team before we close this out? Okay, guys, let's get started with our second slide.
Hi, everyone. My name is Vivian, and I'm a research assistant with the Maryland Addiction Consultation Service, also known as MACS. And today I'll be presenting our poster on the MACS TeleECHO pilot. MACS is a state-funded program that provides support to prescribers in addressing the needs of their patients with substance use disorders and chronic pain management through services such as phone consultation, education and training opportunities, resource and referral identification, and technical assistance. We are funded by the Maryland Department of Health and administered through the University of Maryland School of Medicine here in Baltimore. Our services are directed towards prescribers, and we do not engage directly with any patients. So MACS has adopted the ECHO model to further support prescribers in providing evidence-based addiction treatment to their patients. ECHO is a model developed from the University of New Mexico that uses a hub and spoke approach to virtually connect healthcare prescribers to specialists. ECHO seemed like a good fit for our program as we share the same mission to address the needs of vulnerable populations and deliver locally high quality care. In 2018, MACS proposed an expansion of services, which allowed a team from MACS to be trained at the Institute in New Mexico to become official replication partners. Our pilot cohort was held on the third Wednesday of every month from March 2020 to November 2020. The first 15 minutes of the clinic is a didactic learning presented by one of our MACS physician consultants, which is then preceded by a 45-minute case-based discussion. Participants can present their de-identified case for clinical discussion and recommendations. I think it's also too important to note that in March 2020, the World Health Organization declared COVID a pandemic, which occurred during the same week our ECHO clinic launched. Due to the pandemic, mandated telework requirements were established across Maryland, which did impact our engagement of the cohort. We also had originally planned to have all the MACS consultants in the same room with IT and team members behind the scenes for support, but we quickly readjusted and adapted to the COVID restrictions. After each ECHO clinic, a brief online survey is sent to each attendee through Qualtrics, which is a HIPAA-compliant survey to gain feedback for future clinics. And upon completion of the survey, a free CME or CEU credit is available. Additionally, a pre and post evaluation was sent to ECHO participants to gauge their comfort in addressing patients with an SUD. From our pilot cohort, we had 29 unique prescribers with an average of 10 participants per clinic. As you can see in figure 1, most of our attendees were nurse practitioners or physicians. And although our services are targeted towards prescribers, we were excited to see a wide range of medical and behavioral health professionals. Surprisingly, most of our participants were from urban areas such as Baltimore City. However, we had representation from each region of the state. Response rates were low with an average of 3 to 4 per clinic, but from COVID, we have learned many important lessons and we will implement more aggressive strategies for higher response rates in future cohorts. From table 1, we can see our post-evaluation results. Most prescribers said that they were confident and willing to provide patients with specific advice to help them avoid relapse, provide patients with detailed education about all medication treatment options, and provide comprehensive care to patients for an opioid use disorder. All of our attendees have reported that they are confident and willing to engage with patients who have an opioid use disorder and gain their trust in the future. Our responses support that Max Echo clinics offer valuable education and support to prescribers who manage patients with SUDs. And while COVID required an immediate modification to our program implementation, Max was able to successfully respond and support our prescribers statewide. Our responses also support that Echo clinics improve prescriber SUD knowledge and self-reported quality of patient care. Max is currently hosting our second cohort on registration on opioid treatment programs, and we will soon launch an Echo on maternal opioid misuse. Thanks.
Okay, Vivian, thank you. Team, do we have any questions?
Did you see you said that the number of participants was affected by the pandemic, but I was wondering if, because of the waivers related to the pandemic, if that had any impact on I know the volumes didn't change, but I wondered if the ability for folks to participate, if that improved it or didn't. Just thinking about how some of the waivers for substance abuse may have affected your study.
So our Project Echo coordinator did a lot of outreach that first week when we knew we were going to be launching, and everyone was implementing Tele, and we had a number of providers who indicated that they really wanted to be engaged but just couldn't due to sort of the transformation that every practice was going through to try and implement safety, social distancing precautions, and changing schedules of their patients. So we have continued on with this clinic with kind of a second cohort, and we've definitely seen some of those people who originally registered and planned to attend now attending. But we definitely feel like the comfort of using Zoom and being in videos has really increased the sort of engagement, especially now in our second cohort of people actually being willing to turn on their videos and participate a little bit more than they were the first few sessions. I'm not sure about the waivers of how that implemented it though.
Do you feel that you guys started this at a heck of a time? I mean, this, of all the times to start this, where, I mean, it is the beginning of COVID, where the priorities for all of us changed. Do you feel that now that you're going to continue this into this year, do you feel like there may be an uptick in acceptance because people are actually going to have time to think about something other than COVID?
Yeah, I definitely do. And, part of our change with that knowledge in March was asking them how we could provide additional support. And so we did kind of a poll on topics that that providers really needed additional support in. And for example, implementing tele programs was one area that they all kind of recognized. And so then Max as a Surface designed a webinar on the topic. And we had almost I think over 150 people attend, which was definitely higher engagement than we've seen in any of our previous webinars in the year prior to COVID. So we've definitely seen a lot more engagement with our services since COVID. And while it definitely impacted this Echo, I think the longer that everyone's gotten used to this world, we've seen an uptick. And I think our second cohort will definitely have a much higher level of engagement.
And I think anybody that has done an Echo will say that there's always a group of early adopters that get into it, but Echo is one of these things that kind of builds like a wave, and it takes a while to get some momentum, and you were getting momentum at a time when nobody was paying attention to anything but COVID. So I think this is like your first year. I think it'll be, yeah, I think you'll see it really pick up. So congrats, that's awesome. Guys, we still have some time left. Any more questions? And by the way, we've got 36 people in the call. So again, thank you guys for coming in. I know it's sometimes it's tough to move between sessions.
I do have a question. So, you know, I've heard of Project Echo over the years, but I don't know much depth about it. So can you just tell me for your program, what were some of the important reasons why you chose to go with Project Echo?
Sure. So like Vivian mentioned in the beginning, Max as a service as a whole targets providing support to prescribers. And really the goal is to especially provide that support to providers who may be in rural areas who don't have the same sort of access to grand rounds or, ability to attend CME events that may be, further distance to travel. So offering that continuing education credit in a really accessible way, hopefully, targeting those providers in rural areas. Like Vivian mentioned, we did see the most in urban areas. But part of it was sort of the ethos that Project Echo has in providing the right care at the right time in the right location. They have a lot of really sort of great slogans like that. And we just felt like it really fit in well with our service. And we launched in 2017, and as part of sort of some evaluation efforts of our service, there was a growing demand for continuing education credits, and sort of having our physician consultants travel across the state was becoming really time intensive. So we thought a cost-effective way would be using the ECHO model to be able to provide those continuing education credits to a larger audience and not have to spend the time traveling across the state. If you're familiar with Maryland, our rural areas are really far away, separated by water, and the other side of it separated by mountains. So that travel time was really starting to compete with the growing demand.
Sarah and Vivian, we had a question come up in the chat. I don't know whether you can see that or if you'd like me to repeat that question.
So it looks like comparing individuals to individuals. I know we have provided sort of targeted outreach to folks who have been engaged, and we did notice those patterns. We didn't want to sort of call anyone out and make them feel isolated, but we certainly, as a broader team, have sort of encouraged them to participate in in our ongoing ECHO, as well as our additional educational services, but not sort of specifically mentioning, sort of identifying them. Plus, I know a few of our responses, we put sort of the link in the chat and we follow it up with an email through Qualtrics. So depending on how they respond, we may not always be able to identify who was who responded.
Looks like we have another that came up in the chat. And Vivian, if you wouldn't mind, drop your poster, and Michelle, bring yours up. We still have a couple more minutes, but I don't want to lose any time to switching out the posters. There's looks like we have another question or another comment in the chat. Oh, I see. Yeah, Anita, thank you. So Anita did bring up, I know a lot of you may have missed this. If you want to, you can always catch up with people through the Event Mobi app, where you go to the attendees and reach out to them. You can also reach out in networking events, or you can email them directly. And be sure to vote on the People's Choice poster. it needs to come from our session because these are really well done. Okay, we still have a couple more minutes. Any more questions for that group? Wow, we're being so efficient. All right, Michelle, we're going to bring up the last poster. And we talked about this before we got started. This poster is an outline for a book. Having just gone through several years ago the governance process, there is something for us to all learn in here. So, Michelle, thanks for the poster. Go ahead and get started.
Absolutely. Thank you so much. And thanks to my colleagues for their great posters. I have to go last, so that'll be a hard row for me to hoe here. Everybody did such a great job. So I'm Michelle Hager. I'm the managing partner of Blue Cirrus Consulting. We work across the country with lots of health systems and organizations to help them with lots of different process issues or questions related to telehealth. And in this case, we were working with Carillion Clinic. This was pre-COVID, so the work that we did here was pre-pandemic. And from an organizational perspective, you can see from left to right, I'll kind of go left to right and then down through the presentation. But that organization covers in Virginia, the kind of southwest corner of Virginia. They have a value of providing value to their community, to have courage, commitment, compassion, and curiosity. And then what really was key to the telehealth aspect was their vision in being committed to a common purpose of better patient care, better community health, and lower costs. That just spoke directly to utilizing telehealth to reach some of these patients. As you can imagine, a lot of these patients were coming from very far away, and in a lot of cases would not have received care otherwise. The organizational needs that they had were to improve access to behavioral health, to improve a physician to specialist consultation, improve and implement chronic disease management solutions, and then also streamline compliance. Compliance was a big internal struggle for them. Sometimes this became a barrier to there, and I think I identify that later on in the barrier section in the bottom left. But this was an internal barrier to their processes. Things would sort of come in and then immediately get derailed because of compliance. So we wanted to work with them to try to find a way to meet the compliance needs, but then also to move innovation forward. And this is a common issue that we see with large organizations where they have risk-averse organizations. However, programs like telehealth, innovations like telehealth tend to be more on the edge, trying to be more progressive, which means there's a general struggle, an internal struggle with those types of priorities between those two competing initiatives. The goals for the organization and for the program were to provide connective, convenient, and collaborative care, healthy communities, and clinical advancement and patient safety, to improve innovation, have financial vitality, and create a workforce for the future. So lots of lofty goals within this organization, and we knew that this would speak directly to a virtual health solution, a virtual program, and this was also incorporated into a larger institutional priority, which was to incorporate some of the academic programs that were working in conjunction with Carillion, which were at Virginia Tech. So what we wanted to understand as part of the discovery, we really had a three-part process where we worked through a discovery of understanding the organization. We have a standardized approach to how we work through the challenges that we see within an organization and providing evaluations. And then finally, we provided some analysis, and I'll talk a little bit about how we did that. So in the discovery piece, we look at their vision, their mission, any supporting structures that they may have, such as leadership groups, et cetera. We looked at their main service areas, which you can see in that small pictorial of Virginia above. We looked at their current telehealth services and evaluated those for them for their effectiveness, and then also their strategic partnerships. So were those strategic partnerships, were we able to take advantage of them to improve the innovation to move that telehealth program forward? Our process was to interview stakeholders. This is a pretty standard process that we utilize each time we work with an organization. We want to understand, and lots of times, as you may have heard from the keynote that was just before this poster session, lots of times having those sort of brainstorming sessions with interviewing and stakeholders, you come up with ideas and you learn something a lot from internal folks that may have some good ideas on how to improve solutions. We look at their staffing models and identify those models for them and how they could improve them, job requirements, reviewing the community health needs. So we not only use the community health needs assessment, we do our own research, and that combined with stakeholder interviews, our own research, we get a good picture of the organizational catchment area and how we can improve access to care for those patients. We also looked at evaluating those individual services I mentioned, what their capacity was to improving and to expanding services, and then defining the governance. And we found through this process that we were able to break through and see that governance really became an overriding challenge for this organization. There were lots of reasons for that, and I'll talk through some of those, but we wanted to jump into that particular piece to be able to help smooth that over. This is a large health system, and so a lot of competing interests are happening. And as you may already know, telehealth incorporates not only IT, but process, clinical. I talk about it in terms of if you had to add an emergency room, what would you need? There's so many pieces to telehealth. It's not just putting in the technology. So we really looked at this as a breakthrough through the defining of the governance piece. And we looked at a SWOT analysis. So a real strengths, weaknesses, opportunities, and threats. And I know that some of this slide is going to be small, but you can always look at it later. But at the top side of that circle, those are the internal origin for those strengths and weaknesses, and those that are external, and then a left to right. Those on the left are more helpful. Those on the right were less helpful. And this process of going through the SWOT analysis and identifying the strengths, weaknesses, opportunities, and threats for the organization helped really coalesce their thoughts around how they needed to move forward with their program, and also how do they deal internally with the struggles that they were having to move a big innovation program forward, and also change some thoughts around how telehealth should be perceived, and not having it be just an IT or technology, implementation. And you can see in the bottom left-hand corner, that was one of the larger pieces of this, was identifying the barriers and seeing where we could smooth those barriers out, move in different directions, try to find ways for people to understand why we didn't need to go through the exact same process as every single other change management that may have existed in the organization. So one of the big challenges was the internal processes were confusing. You can just see a little graphic behind on that piece of the slide there, or that piece of the image. And that represented something that they internally called chutes and ladders. So it was an internal process which worked well from a change management perspective on IT, but did not work well from a clinical perspective. And so looking at those internal processes and how we could try to smooth that out or streamline that was a big piece of this project. Duplicate processes for chain requests. A lot of times we saw things coming in from multiple places for the same exact thing. So their governance structure wasn't set up to be able to filter through and determine whether or not, oh, we don't need to look at this again. We've already reviewed this and we can see this. So time would pass and they wouldn't necessarily know that the same program had come up again and what the evaluation was of that, or where that was in the prioritization list of all the programs that happen in a large health system. So as you can see in that third bullet point, there was little to no prioritization. So sort of if you came in first, you got first serve. So we wanted to look at how do we prioritize these programs and make the steering committee more effective, because you can see as the final bullet point there, the steering committee was perceived as ineffective. So there were some of the right people on their governance structure. However, the way that that program operated or that steering committee operated did not result in actions and did not result in decisions. So we looked at where they landed in the telehealth maturity model there. And I know those words are far too small for you to see, but essentially this is a model that Blue Cirrus developed. It's based off of the MRAM meaningful use or EMR acceptance model, as well as kind of emerge into Gartner's model as well, kind of keeping a familiarity of that. So it goes through an 8-stage process from organizations that are at isolated explorers that haven't really done much inside of an organization. And then in the columns, it looks at governance, vision and strategy, the people that are needed to be able to do telehealth, the technology, the clinical processes. So are we putting the right workflows in place? Are we identifying performance metrics in the way that we should? And then we identify the value that you should get at this stage in your maturity of your telehealth program, your virtual health program, and then some examples of the types of organizations over to the far right. So you can zoom in on that. I think the slide, the poster is saved, so you can zoom in on that section. And then finally, the governance itself, we really wanted to structure something really cleanly. We wanted it to be very, very clear to the organization, and we didn't want to leave anyone out either, because lots of folks wanted to be involved in this new and interesting internal program that we knew and everyone recognized was going to be help them to be able to reach more people in the state of Virginia and their catchment area. But we needed to help them understand how that governance structure should work so that each step they could have an action and decision that would be made in those steps so that everything didn't go to the top. And that's what we saw previously. So we looked at work groups and how do those work groups work together? What's the purpose of those work groups? What kinds of changes are they overseeing? What's their authority? And who chairs those work groups? The telehealth department, what is their authority? What's their purpose? And who chairs the telehealth department? Obviously that telehealth director. And then the steering committee, looking at what's the purpose of that steering committee? What are you supposed to be making a decision about? What are the types of changes that come to the steering committee itself? And then what's your authority? So many times what we see as a steering committee tends to be a sort of idea committee. And this was what was happening here. So we streamlined that to say this should be a decision committee. This is not where ideas come in the steering committee. Ideas are done at work groups and at the telehealth department level. Decisions come to the steering committee themselves. They should have an authority to identify and move budget around as it exists already. So previously budgeted dollars might be moving those around. So for example, one resource moving to another project. Those things that required additional resources or were large scale, included strategic direction types of programs, went to the executive leadership team. So it seems we wanted to keep this process simple, and it does seem like, oh yeah, that's common sense, but that is not necessarily how sometimes these programs how they evolve over time. Because telehealth is such a new and innovative technology, sometimes we see evolution happening that isn't necessarily healthy evolution. So we found that breakthrough in going through this process, and I think that you probably can take some nuggets away for your own organization, and hopefully you'll be able to look at the more detailed pieces of this governance structure as well as the maturity model. So I'll take some questions. And I should say we were all very honored to work with Carillion. It's a great organization, very focused on patient care and very focused on innovation. So thank you to the group there as well.
Okay, guys, we have a minute. Any questions? I mean, if no other questions, Michelle, one that I had was within the governance, did you create any kind of a numeric or quantitative scale to assess new ideas to help with the prioritization?
We did. We identified, we did create we have a process or a method that we utilize that identifies the complexity of the program, the effort that it will take to do that program. And then also it's kind of a matrix. So it'll show whether or not this is a highly scored an innovation. What does it include multiple clinicians? Does it have an organizational benefit? I can't remember. There's like 6 or 8 different numbers, but there's a whole bunch of values associated with that. And we complete that with the organization and leave that tool with the organization, because as new programs come along, they need to know, is this a high scored type of program, or is this a low scored type of program? Because we all don't have unlimited resources, right? So we have to move things, and we have to have some kind of a governance. Everybody wants things right away. In this case, I know we had orthopedic folks that wanted stuff tomorrow, and we understood that completely. But we had to look at what was possible within the resource structure. So yes, it's an effort impact matrix along with a prioritization scale as well as implementation.
Okay, guys. Well, thanks everybody for attending today. And also be sure to vote for the People's Choice Awards for the posters, and needs to be one of our 3 because they were outstanding work. So thanks everybody for participating, and we'll see you at the rest of the conference.